We will just welcome our guests again. Thank you for joining us in this meeting. I'll just have a very short talk about our experience in ASD device closure in our congenital and structural heart disease unit, which is a subunit of the cardiology department responsible for the management of congenital heart disease, irrespective of the age, actually, from the pediatric age group to the adulthood. Our unit in its current status was established in 1990, and we have currently 16 staff members. We have one biplane CAS suite and 3 echocardiographic machines dedicated for the congenital unit. We have 4 days per week for the catheterization unit, and we have 2 days per week working for the echo unit. And these could achieve about 800 to 1,000 cardiac catheterization per year and about 2,500 echocardiographic examination per year. The ASD device closure in its current protocol was established in 2005, and the PFO closure was followed in 2013. The current inventory started with the Amplatzer ASD occluder, whether the classic Amplatzer occluder or the cribriform device, and then this was followed up by the Figula Occlutech device, which we are very familiar with in our center. And then the CE mark devices, including the COMED and Cocoon devices, which were introduced into the Egyptian market a few years ago. The ASD device closure is usually part of our structured training for our fellows, which usually pass through a 2-year fellowship training in intervention, and this is a compilation of multiple cases in one video clip to show the different maneuvers to deploy the ASD device, whether through the classic left atrium approach or through upper and right or upper left pulmonary vein approach. Our training include proctorship training in the first place, and then we tend to keep the fellow doing the cases under supervision for a certain number of cases, and then to be dependable, doing the cases on their own, but still under a senior supervision in the cath lab around, just in case there is some difficult cases. We have also introduced the 3D transesophageal echo guidance about 5 or 6 years ago, and it is usually very helpful in difficult cases. This is a case where we have a fenestrated septum including multiple defects and a larger defect in the same patient, and we could emphasize here the very great benefit of the on-fast view or the anatomical views of the 3D transesophageal echo, where we could see accurately the catheter, where it is passing directly, whether through the fenestrated part or through the single defect. And on the other side, we could place 2 different devices, the cribriform device in the fenestrated part and a smaller classic ASD device in the larger defect. The average annual ASD device closure in our unit approaches or approximately 60 cases per year for the last 14 or 15 years. Since the renovation of the unit, our unit has been totally renovated in January 2017. We placed 185 devices successfully in 181 patients, because 4 patients had 2 devices in the same setting. 51% of our patients were females. The median age was 9 years, the youngest was 6 months old, and the oldest was 65 years. Device size, median size was 18, and we used all range of sizes from the smallest 8mm device to the largest 40mm device. The median QP over QS was 1.75. Minor and major complications occurred in 11 cases, representing 6% of these cases. 2 patients had first-degree heart block post-deployment, which was stationary on follow-up and did not require further management. 3 patients had thrombus formation on the device during procedure, which obviously was due to the inadequate anticoagulation and the drop of the unexplained drop of ACT during the procedure. But luckily enough, they resolved spontaneously by anticoagulation, and we did not need to extract the device in either of these patients. We have 2 documented cases of nickel allergy, which were diagnosed by nickel patch test and the FEN test. Both patients refused to extract the device and they are just living with a nickel allergy. 2 patients had intra-procedural perforations, one of which was self-limited and the other was referred to surgery. Device embolization occurred in 4 cases throughout the entire 14 years of the program, 2 of which were successfully retrieved percutaneously. This is a case where the device embolized to the aortic arch and was discovered 1 day later, actually during routine pre-discharge echocardiogram, and it could be successfully snared using a larger Mullen sheath into the sheath and without any damage to the aortic arch. And this same patient was managed in the same setting with a larger device to close her ASD. We tend to have a decent amount of research regarding our patients. This is a paper published back in 2015 detailing the immediate and short-term effect of percutaneous atrial septal defect device closure on cardiac electrical remodeling in children. It was a smaller series of patients, including 30 patients with a median age of 6 years. The ASD diameter was around 16 and the balloon stretcher diameter for patients where we did balloon sizing was 18. We did balloon sizing in 18 out of these 30 patients, and we could prove that the electrical remodeling actually improved starting from the first day post deployment, and this improvement was significant and sustained through a 6 months follow-up period. We have currently a registered clinical trial ongoing, recruiting patients for assessment of left ventricle and right ventricle strain and strain rate before and after percutaneous closure of the ASDs. This is done in collaboration with Asyut University and Ain Shams University, and we are still recruiting patients for this trial. We have a couple of abstract publications in international conferences related to this trial. This is an abstract detailing the effect of device size on the change in ventricular function post-transcatheter device closure, and in this particular abstract we actually could prove that the device size has no effect on the ventricular function, unlike the previous literature which had a theory that larger devices tend to impair the ventricular function on the strain level. This is another abstract presentation just published 2 months ago in the PICS 2019 about a novel 3-dimensional echocardiographic technique for device size selection in patients undergoing ASD transcatheter closure. But of course we still have limitations. Financial limitations is a major issue because 80% of the patients are sponsored by charity and NGOs, as the service is not yet covered by the current medical insurance system of the government, and the devices are expensive compared to surgical closure, which is 100% insured. Also, we have limitations related to registry and data collection. We need standardization and integration of professional softwares for registry and data collection and statistical analysis, as most of the published data are single center experience, despite the fact that Egypt is among the first 4 countries in the Middle East and the first in Africa in device closure based on the manufacturer's sales data. Actually, this is based on how many devices are being sold in each country, and we tend to be one of the leading countries in this area in consumption of devices, whether in ASD closure or in other defect closure. Also, we have an issue related to non-compliance of patients for long-term follow-up, because this is a tertiary center and most of our patients can come from every place in this country. So patients who live at quite a long distance from the center tend to be reluctant to follow up unless they are in need of this follow-up. Whenever they feel they are good, they tend to lose follow-up periods. Our future perspectives include increase the availability of the service throughout collaboration with the Ministry of Health to include different device closure procedures within the medical insurance system. Also, we need to increase the cooperation with centers of excellence worldwide to promote patient services, registries, and multi-center trials. We had a recently established protocol with the stroke unit in the neurology department in 2018 to properly diagnose and hence treat cryptogenic stroke, and we have investigated 46 patients and we have closed 6 patients with various interatrial septal pathologies, whether PFOs, fenestrated septum, or aneurysm. Also, we are very keen to use state-of-the-art devices whenever they are possible and available in the Egyptian market, including the bioabsorbable septal occluders, which of course would present a great advantage, as there will be no metal left behind and no erosions, and thus allowing future access for the left atrium for any future procedure for these patients. Thank you.